Good afternoon, dear audience. I'm going to talk about my PhD thesis, Diagnostic and Therapeutic Options in Sepsis and Trauma-Associated Coagulopathy. My name is Tímea Mátyási-Dombi. I'm a second-year PhD student and specialist in anesthesia and intensive care, currently working in Manningerjenő Trauma Center, Budapest. My vision is to provide efficient hemostasis care for septic and trauma patients worldwide. Therefore, I would like to improve personalized hemostasis management for critically ill individuals. I currently have 2 ongoing projects. Both of them use the method of meta-analysis. First, I investigate the efficacy and safety profile of thrombomodulin in sepsis-associated coagulopathy. Sepsis can disrupt the balance of hemostasis in 1/3 of the cases. It causes microthrombi and leads to various organ dysfunctions and even death in every second case. Thrombomodulin, an anticoagulant agent with anti-inflammatory and antifibrinolytic activity, so it can reset this balance and add to adjuvant therapy in sepsis. However, the recent guidelines are controversial. The Japanese guideline recommends the using of thrombomodulin, while the International Surviving Sepsis guideline does not include it. So our aim was to investigate the possible clinical benefits of thrombomodulin in treating sepsis-associated coagulopathy. This is our clinical question, and we use the PICO framework. Patients with sepsis-associated coagulopathy were investigated. The intervention was thrombomodulin, and the control group was standard of care. We investigated mortality and different secondary clinical outcomes as well. We conducted a systematic search with this search key last year, and after the selection process, we found 33 eligible articles for our study. I would like to present my results. The first investigated outcome was 28-day mortality, measured in odds ratio. We had more than 8,500 patients. The overall effect of thrombomodulin was 0.65, which means that the odds ratio of death was decreased by 1/3. We evaluated these studies separately as well. The RCTs, the propensity score matched, and non-randomized observational studies were the subgroups. The highest effect was in the observational study group, where the odds ratio of death was decreased to half, and it was mathematically and statistically significant as well. However, in the propensity score matched group and the RCT group, there was a strong tendency to reduce mortality. The statistical significance wasn't reached. There was an even more remarkable effect in intensive care unit mortality, where the odds ratio was decreased to half in intensive care unit, intensive care patients. Another outcome we investigated was the resolution of coagulopathy. We can quantify the severity of coagulopathy by different score systems. For our investigation, we used the Japanese Society on Acute Medicine DIC score range. There were no difference in the DIC scores between thrombomodulin and the standard of care group. However, after 6 days of thrombomodulin therapy, we saw that the DIC score was significantly lower, around 1 point lower after the therapy. It is clinically and statistically significant because it clinically translates to the resolution of coagulopathy, which was 4 times higher, almost 4 times higher in the thrombomodulin group compared to the control. With the resolution of coagulopathy, we can expect improvement in the organ functions. That's why we investigated SOFA scores as an outcome. SOFA score can assess the organ dysfunction for the physicians. The higher the score, the more severe the patient is, and the higher probability to have a high risk for mortality as well. We could only see a slightly improvement in the SOFA score, which didn't reach the statistical significance, unfortunately. Another organ dysfunction was the ventilatory-free days within 28 days. We compared the mechanical ventilation between these two groups, and we found that 1.5 days were in the thrombomodulin group. The ventilation was 1.5 days shorter than in the control group, and it's also statistically and clinically significant because the shorter ventilation can lead to less complications, for example, infections. Regarding our safety outcome, we compared bleeding rate between the groups, and we saw no difference in bleeding rate neither during thrombomodulin therapy and not after the therapy. So thrombomodulin is safe. Our study have some strengths. RCTs and non-randomized studies were evaluated separately. We had more than 8,000 patients investigated in the primary outcome. However, the limited number of RCTs, the mostly Japanese studies, and the potential overlap of the patients in registry analysis limit our result. We can conclude that the resolution of coagulopathy induced by thrombomodulin leads to better organ functions and reduces mortality in SAC. We should refine guidelines for thrombomodulin use in septic coagulopathy, and we should definitely plan a multi-center RCT in a specific patient population. My first study is in an advanced stage. We have submitted it to the D1 journal Intensive Care Medicine last week, and it is under review right now. We hope to get a green light soon. My second project is about investigating the efficacy and safety of early fibrinogen supplementation in patients with severe trauma. The leading cause of mortality among young people is still massive trauma injury, which can be worsened by trauma-induced coagulopathy in around 1/3 of the cases. The loss of fibrinogen and the increased fibrinolysis lead to low levels of fibrinogen, and it can be an independent predictor of death. The recent 2023 trauma guideline states that the fibrinogen level should be maintained above 1.5 gram per liter. We can use fibrinogen concentrate, but we don't know how much concentrate and when is the best timing of this treatment. So we plan to investigate the potential benefit of early administration of fibrinogen in patients with severe trauma. This is our clinical question. We use also the PICO framework. Mortality is our primary outcome and different secondary clinical outcomes. after the preliminary search, we plan to submit a Prospero and continue my project. I hope to have my first project be published soon, and plan to continue with the second project this year. Thank you very much for your attention. I would like to say goodbye with these words. Every person needs a broader perspective to see more and to be aware of the divine nature. In a broader perspective, we find a new perspective. In a new perspective, we find a new life. Thank you for your attention.
All right, so let me ask a question about your first project. So the change in the DIC scores were quite shocking, and they're quite significant. Surely the intervention itself helped. It's an anticoagulant. But the question is, did all the patients receive standard of care anticoagulation, therapeutic level of anticoagulation, and on top of that, thrombomodulin? Or were there some instances where thrombomodulin was compared to no therapeutic anticoagulation?
Yeah, thank you for a question. I have to say that there was a heterogeneity in this question, because we had to compare different studies. In Europe and in America, we usually use other anti-therapeutic for prophylaxis as well. But for example, in Japan, they do not use it every time, because there are differences. So we had to. We plan to make a subgroup analysis on these heterogeneities of standard of care, but actually they were so mixed in each studies that we couldn't separate them well. That's why it is the studies should be planned well before doing them.
That's the key point, right? So if you're doing a clinical study, you should really think about it. Speaking of clinical studies, you said that we urgently need some proper randomized controlled trials about thrombomodulin and different patient groups and stratification. And then you jump onto another meta-analysis project. Why not have a thrombomodulin clinical study in Hungary?
We plan, but to make a good protocol, we have to make further investigation. For example, the infection site is also an important question, and there are some data which indicates that it's also important in choosing the patient population, but we have to make further research to specify it.